Welcome everyone. This is the Pain in the Neck webinar. We're going to review cervical IVDD tonight. Hopefully everybody can hear me. We have Ashley just kind of monitoring for technical glitches and things like that. So Ashley, if you can hear me, just give me a thumbs down if we have any issues. Otherwise, we will get started. So first and foremost, I want to thank everyone for joining us tonight. I'm certainly excited to be talking about something that I love and sharing my knowledge with some of you. So just a little bit about myself. My name's Montana DiVita. I graduated vet school in 2016. I graduated from Ross University. I did my clinical year at North Carolina State University, which is where I really fell in love with neurology and was able to kind of switch my focus to neurology as opposed to surgery, which was initially what I thought I would do. Then I did a rotating internship at Carolina Vet Specialists in Winston-Salem, North Carolina. I did a neuro internship at Blue Pearl in Atlanta, and then ended myself here in Miami for a neurology residency. So I'm super happy to be here at Southeast Veterinary Neurology, just coming to the final few weeks of my first year. It's been great so far. So again, I thank y'all for joining me tonight. Special thanks to the Broward County Veterinary Medical Association. So I think we ended up skipping over their slide. But we're doing this in conjunction with their kind of monthly meeting. So I certainly appreciate y'all letting me share tonight with you and presenting to y'all and that you're joining me tonight. So we'll kind of jump into things here. Tonight we'll be talking about cervical IVDD in dogs. Last month for our webinar series, Dr. Fitz spoke about IVDD in general and focused mainly on the thoracolumbar spine. There are definitely differences between the back and the neck. Clinical signs, severity, obviously surgical approaches as well. So we'll talk a little bit more specifically about IVDD in the neck, but we'll also review some of the anatomy and things like that I'm sure Dr. Fitz reviewed in her webinar last month. So some of the things that we'll talk about are exactly what is IVDD, what are the clinical signs associated with IVDD, and when should I worry about IVDD in my pets or my patients. So I know we have some pet owners here, and I think recognizing that there's a serious issue is certainly really important in getting your pet the care that they need. Next thing we'll talk about is what is the treatment for IVDD? What is the prognosis for cervical IVDD with some of our different treatment options? And then we'll go over some cases throughout the presentation, but we'll also chat at the end about one interesting case in particular. And then just some housekeeping from here as well. We will take questions at the end. About the last 10 minutes or so will be for questions. Ashley will be helping to go through the questions so that I'm not kind of distracted. But if we don't get to your question, we will answer you by email. You'll also get your CE certificate about an hour after the end of the lecture, so about 9 o'clock Eastern time this evening. If there are any issues with that, just reach out to us and we'll make sure that you get that CE certificate. So moving on here, first we'll talk about the anatomy of the intervertebral disc. So this is kind of a head-on view of the spine, or an axial or transverse image. This is the bone of the spine here, encasing the spinal cord within the spinal canal. And the intervertebral disc sits below the spinal cord, and it acts like a shock absorber. So the intervertebral disc is made up of two parts. The first part is the annulus fibrosus. So the annulus is, again, like the name says, a fibrous material. It's arranged in layers, so concentric layers, and it houses the nucleus pulposus. The nucleus is more of a jelly-like material. So I like to compare this when I'm talking to owners to a jelly donut. The annulus would be the jelly the cake part of the donut with more of that kind of cartilaginous fibrous, excuse me, fibrous kind of feel to it. It's a little bit tougher than the inside, which is the jelly donut-like portion or the nucleus. Over time, they can degenerate, and we'll talk a little bit more in just a moment about degeneration of either the annulus or the nucleus and what that means for our pets. So again, the jelly donut is my favorite analogy to what the intervertebral disc is like. And remembering that they are supposed to be shock absorbers. So the role of the disc is to distribute forces and pressure and torque that occurs during daily activity on the spinal cord so that we don't get injured. Obviously, when they get old and degenerate, that ability is decreased a bit. Moving on here to the anatomy of the bones of the cervical spine. So we have 7 bones of the cervical spine. This first bone obviously looks very different than the rest. That's the atlas. We have the axis or C2. And then the rest of the bones of the spine you can see here. The bones of the kind of chest area start at T1, and that's where the ribs come off. And that's again when they change in anatomy quite significantly. You can see the wings of C6 here. So most dogs have those prominent wings, and that helps a lot as an anatomical marker for us during surgery or when we're preparing for surgery. And the discs would actually lie in between these bones here. So underneath the spinal canal, with the spinal canal being in the center. I'm hoping y'all can see my pointer and see all of that. Then if we move on again, to more of the soft tissue structure of the spine. So waiting for my screen here there we go. So this would be the spinal cord in this image. And of course, this is a loose depiction with the bones kind of being on the bottom. The top part of the bones that helps to encase the spinal cord is obviously not pictured here. Showing the different segments of the spinal cord, and again, the bones of the thoracic spine or of the chest would be starting right about here. We can see importantly though that the nerves exit the spinal cord, and those are the nerves that help to supply all of the other structures of the body. This kind of big or bulging area of the spinal cord here is called the cervical intumescence from C6 to T2. And that's where all of the nerves that provide innervation to the front legs come out of. So that's obviously a really important area of our spinal cord. We split up our localizations into these different sections, the C1 to C5, C6 to T2, and then the thoracolumbar and lumbosacral localizations, because we can get different clinical signs with those different sections being affected. Sometimes they're similar clinical signs, but sometimes it can help us in our clinical decision making, as well as knowing where to look for a problem. And so we'll move on to what is IVDD. So IVDD stands for intervertebral disc disease. And IVDD is a degenerative process, which is the predisposing factor for disc herniations. So oftentimes my clients will hear me refer to a disc as a slip disc or a ruptured disc or a herniated disc. And that's the actual process of the disc entering the spinal canal and putting pressure on the spinal cord. Intervertebral disc disease is the degeneration and the aging of the disc that makes it more likely to slip or herniate or rupture. All of those kind of mean the same thing. So we have a few different types of disc slips or ruptures or things like that. They're split up into Hansen types. Hansen was the first person to describe these. Hansen type 1 is one of our most common types of disc slips. So this is most common in our smaller chondrodystrophic dogs. And for our pet parents, a chondrodystrophic dog is one that typically has a longer back and kind of short, stubby legs. In those breeds, like Dachshunds and Shih Tzus and French Bulldogs, the cartilage doesn't form quite as well as it would in a different breed. And that cartilage that forms differently is what predisposes the disc to having degeneration. So in Hansen type 1 disc disease, the nucleus, that jelly-like center, becomes dehydrated. It gets really dry. It fills in with a calcium or a bone-like material and even gets a little bit gritty. And that nucleus, again, this is common in chondrodystrophic dogs, that nucleus can start to rub away at the annulus and can also weaken the annulus, or again, that fibrous part of the disc. You'll notice in the next few pictures, or even in the picture on the previous slide, that the nucleus is kind of dorsally deviated. So when we have that weaker disc, the nucleus is going to be most likely to push dorsally because there's a weaker annulus in that area. So when we have Hansen type 1 disc disease, when we have that degeneration of the disc, there's a change in the pressure and the force distribution in the disc where it wants to push upward towards the thinner part of the annulus. Then we have Hansen type 2 disc disease, and this is where the annulus degenerates. It can become quite thick and it actually protrudes into the spinal canal. This is most common in our non-chondrodystrophic breeds. So we do see Hansen type 2 disc disease in our older large breed dogs typically, with usually more of a chronic insidious onset. They can have acute worsening, but we usually have a more long-term history, whereas with our Hansen type 1 disc disease, we typically have a pretty acute history. The last type, which we won't really talk about too much today, is Hansen type 3 disc herniations, or what's called a missile disc. A missile disc is a very small volume of disc herniation that happens rapidly, and it essentially bruises the spinal cord. So a small volume, high velocity disc herniation. That's not a compressive disc herniation, and so we'll kind of steer away from that for this conversation, but it is important to know about because it does occur and it does make dogs look exactly like they would look if they had a different type of disc herniation. So just another graphic here again. This is a normal disc on top with the nucleus in the middle, the annulus outside, and the spinal cord here in the spinal canal. This is a Hansen type 1 on the bottom left, and we call that an extrusion. So you can see the tear in the annulus. That's actually part of the pain associated with a disc herniation, is that tear. And then the nucleus is extruded into the spinal canal and pressing on the spinal cord. In Hansen type 2, it's more of a protrusion, so the annulus gets thick as it degenerates and it kind of protrudes into the spinal canal. Can still cause compression, but again, it's typically more of a chronic, slow onset in those dogs. So some breed predispositions to IVDD, as we mentioned, are chondrodystrophic breeds, so dachshunds are certainly our poster child. Here in Miami, we see a ton of French bulldogs, and I don't know if that's because they're super popular in Miami or because we're kind of shifting in terms of our genetics and how we're breeding them, but we see them a lot. And Shih Tzus, other kind of small breed Lhasa Apsos, we can certainly see them. We see a lot of Chihuahuas too, Yorkies, other small breed dogs, and typically those are the guys that are jumping on and off the couch and zooming around the house. So those extra forces, extra stress and strain certainly do predispose these small guys to disc herniations. However, we also see lots of large breed dogs, so our Labradors and Labrador mixes. They definitely get disc herniations. We've seen quite a few of them in this last year, and they like to get them in the neck. We see a number of pit bulls. I don't know how many pit bulls I've seen with a disc herniation in the neck, but certainly possible. I think there's one in this presentation. And the last dogs that we see pretty commonly of the large breed dogs are Rottweilers, other large kind of giant-ish breed dogs. So the kind of point of this slide is that any dog can have a disc herniation. So just because it's not a dachshund or a French bulldog, we shouldn't discount it as a possibility. Not every dog reads the book, so to speak, so we should always keep it on our differential list. All right. I'm having trouble. Here we go. Okay. So first we'll go into all of the clinical signs of IVDD, and there are certainly variable clinical signs. So pain is certainly one of our most common clinical signs of cervical IVDD. They can have difficulty walking, which can manifest as a weakness, a lameness, or ataxia. And again, for our pet parents, ataxia is a kind of drunken gait, difficulty knowing where our legs are, so more of the wobbliness of the gait as opposed to weakness. They can have proprioceptive deficits or not knowing where their legs are. So when I flip their feet over, they should flip them right back to a normal position. But some of these guys will leave their paws upside down if I flip them over. They can have a head turn. So some of them won't want to move because they're so painful. They can have decreased or absent thoracic limb reflexes, and that would be more with that C6 to T2 localization. They can have Horner syndrome, which we'll talk about in a moment. And in the most severe of cases, we can see dogs have difficulty breathing. I mean, obviously, that's an emergency situation. So first, we'll talk about pain and discomfort. So this is arguably our most common presenting complaint for a dog that we diagnose with cervical IVDD. Sometimes it's the only presenting complaint. So typically we'll see these dogs have a low head and neck carriage. So they're kind of holding their head down to the ground. They don't want to look up at the owner. You know, when they're looking around, they'll look around only with their eyes as opposed to moving their head. When they greet the owner, they'll be super excited to see the owner, but they'll only look up with their eyes and they won't actually lift their head up. And that's a sign of pretty significant neck pain. We can also see them spontaneously crying out. So lots of times we'll hear owners tell us, oh, every time she gets up from her bed, she cries out, something similar to that. So that's definitely one of the possibilities. Freezing in space is a funny one. So sometimes we do see these dogs for episodes. So quote unquote episodes of kind of freezing in space. There we go. I'll use the keyboard from here on. So episodes of just freezing and staring, and we obviously talk about, is this an atypical seizure? But sometimes when we examine those dogs, they will have neck pain on palpation. And so the freezing part of it is if they suddenly become painful, we assume that they just don't want to move, don't want to look around. And I'd say we see a pretty significant amount of dogs with that presenting complaint. We can also see kyphosis or an arched back, and we can see a change in behavior. So either becoming aggressive with housemates that they previously got along with, being really lethargic or hiding. So any change in behavior can be indicative of discomfort, even if they don't have signs that are as significant as some of the ones listed here. You can see with this dachshund here, he's pretty painful just based on this picture. You can see his arched back and his low head and neck carriage. You can almost imagine that he's trying to, kind of tiptoe around if he were to walk because he doesn't want to move too fast. So I would bet that this dog was in pretty significant pain when this photo was taken. So here we have a video. This is Maui. Maui was a 2-year-old male-neutered French bulldog. He had kind of a 2-day history of discomfort. He was doing lots of the things we just mentioned, crying out, wasn't wanting to go up and down stairs. And he saw his primary veterinarian who thought he had some neck pain and prescribed him some medications. Unfortunately, he just didn't get better, and his mom was really concerned about him. And so she brought him into us, and I'll play the videos. They're a little bit subtle, but we can see here that he's kind of holding his head and neck in a guarded position. He's got his ears pinned back, and likely because he's so uncomfortable. This was just prior to him being admitted. Play it once more for you here, and I have another one of him. And so we can see he's pretty uncomfortable there. In the next video, we'll see Maui again. And here he is again. And you'll see him looking around, but mostly with his eyes. He doesn't really want to move his head too much. Moves it a little bit, but you can see his eyes flicker back and forth. And he really was super painful. He was having muscle spasms in his neck, as you can see there as well. And I'll play it one more time. Right in the beginning, you see a muscle spasm. So we did do an MRI. We found a slip disc at C3-4 for him. And by about 2 days after surgery, he was feeling great and never looked back. He's doing great since then as well. So pain will kind of split up into 3 different types of pain. There are actually no pain receptors in the spinal cord itself, so that's not the painful part of things. However, there are 3 different types of pain that can be caused by a slipped disc or by IVDD. The 3 kinds of pain that we think about are discogenic pain. So when we get that tear in the annulus like we saw on that previous slide, that's actually painful. The annulus or the disc itself is innervated. It doesn't have a vascular supply, but it does have nervous supply. And so when it tears, that's a pretty painful feeling, I would imagine. And so that can be part of our pain. We also can have meningeal pain. So when the disc enters the spinal canal, it can press on the meninges. And again, we'll see a picture of what that looks like in just a moment. It can also irritate the meninges and cause an inflammatory response, which then causes meningeal pain as well. And lastly, we have radicular pain or nerve root pain. And that's what a lot of my owners can relate to is, oh, my doctor said that my dog must have a pinched nerve. And it's essentially the same thing. So radicular pain is when the nerve root is compressed, and that is also super uncomfortable for these dogs. So here is just another anatomy lesson for you. We have, again, this transverse image. The spinal cord is in the center here. This is just to show the meninges. So the meninges kind of outline the spinal cord. And when we have a disc that presses on the spinal cord, that can be super painful because the meninges do have pain receptors. So that's just to show that. The nerve roots also exit here from the intervertebral foramen, which is at the joint of 2 successive vertebrae. So here we are again, and we have again a nerve root compression here. So you can see that disc slipping up and a little bit to the side and pressing on the nerve root. And that can be one of our major sources of pain for these guys, even though this disc isn't pressing on the spinal cord too much. And I would bet if this were, if this were a true life situation, that this dog wouldn't have too many deficits other than discomfort and potentially a root signature, which I think we talk about coming up here soon. So this is a CAT scan. This is, again, a real life example of that. And this is kind of successive slices of the CAT scans. This is a patient named Johnny that came to us for episodes of crying out. He did have a history of a slipped disc in his back, so his owners knew where to come. And we ended up doing an MRI. The findings were a little bit subtle, so we followed up with a CT scan or a CAT scan, which is much better at looking at bone. And we see here, this is kind of the vertebral body. We don't have him, or the slice is perfectly straight, so we can't see quite the whole thing. But this is more what a normal vertebral body looks like. And then we move here back a little bit caudally. We start to see the articulation or the joint. So this is the articulation of this bone and the one behind it. And again, we kind of missed that on this side. But what I want you all to notice is that we have here the intervertebral foramen, and you can see on this left side of the screen that it's kind of that grayish color, which represents soft tissue on CT, so the nerve root, as well as some fat that exits in that area, and vessels, and it's nice and clear here. When we look on the right side of the image, we have a really bright piece of material in there, and again, remembering on CT that bone is bright. So this looks like a bone, and why is that? Again, if we move to this last picture here on the right, we see a really significant piece of what looks like bone in that intervertebral foramen where that nerve root would be located. And so this was actually degenerated disc material that had herniated off to the side. It was pressing on his nerve root and causing him discomfort. The rest of his exam was normal. Thankfully for Johnny, we were able to go in surgically and remove that big chunk of degenerated disc material, and he started to recover shortly after surgery. So moving on to another clinical sign of IVDD, so a root signature. A root signature is when we see a dog holding up a thoracic limb or a thoracic limb lameness. It's due to pathology of the nerve root. So again, in that kind of radicular pain situation or that nerve root compression, we can see this clinical sign. It'll be seen only with a caudal cervical disc herniation, so from C5, 6, C6, 7, or C7, T1. You can also appreciate root signature, you can appreciate pain as well if you're performing a full kind of range of motion exam of that limb. So when you're putting traction on the limb, they'll be pretty uncomfortable most of the time. And it's due to a lateralized compression, like we just saw in the last slide. So this video here, this one I grabbed from the internet. I've got another one here from one of our patients. So this one's a little more subtle. We can see this beagle walking. He starts to hold up the left thoracic limb. You can see he does that kind of freezing in space motion as well. And then he works himself out of it and goes back to more normal. He does have a subtle lameness there, but it's a little bit more subtle than the next video that I'll show you. And so again, folds up the limb, freezes in space a little bit. Oh gosh, so sensitive. And then we see him there freezing in space, folding up the limb, and then he'll come and be more normal with a very subtle lameness afterwards. If we see here, this is a beagle as well, a 7-year-old beagle that we saw for neck pain and difficulty walking. He had neck pain initially, didn't respond to medications, and then developed this also left thoracic limb lameness. So if we see him, you can see his lameness is much more significant. And even though he looks like he could be a dog with an orthopedic problem, he had really, really significant neck pain and a proprioceptive deficit. So his neurologic exam was convincingly a spinal cord problem, but he absolutely refused to put that leg down. It was super painful when you tried to manipulate that leg. So he is getting some medications, and I think he's going to return in just a few days for an MRI scan. So another clinical sign of disc disease in the cervical spine is hyporeflexia, or a loss of thoracic limb reflexes. So there are 3 reflexes that we test. I realize I only listed 2 here. The withdrawal reflex is the one I care about most. The biceps tendon reflex and triceps tendon reflex can also be tested, but are much, much less reliable. So the withdrawal reflex, again, in bold because it's the one that I test most frequently and that I trust the most. You perform this reflex by pinching on the webbing in between the toes of the front legs, and you watch for flexion of all of the joints of the leg. So remembering that the withdrawal reflex has to be differentiated from a pain response. So some dogs absolutely feel their toes. They don't like me pinching them, but they cannot pull their leg away from me. And also remembering that we should watch for flexion of each and every one of the joints. If they can't flex all of the joints, it can be a partial withdrawal reflex deficit or a diminished reflex, but it's not normal if they're not flexing all of those joints. So this reflex tests the median ulnar, musculocutaneous, and axillary nerves and can be caused by lesions at C6 to T1 spinal nerves, so in that caudal cervical region. The triceps tendon reflex is a reflex that will cause extension of the elbow if you give a little tap on the triceps tendon. This reflex tests the radial nerve, which is spinal nerves C7 to T2. So again, kind of more towards the caudal edge of the region that we're talking about today. And then the biceps tendon reflex, I almost never use because it's super unreliable. So you'll see slight contraction of the biceps. It can be hard to elicit this reflex even in a totally normal dog. So I encourage our practitioners to trust the withdrawal reflex more than you trust any of these other 2. And then the biceps tendon reflex does test the musculocutaneous nerve, which is spinal nerve C6 to C8. So just some pictures here of testing those 2 reflexes. So the triceps tendon reflex, again, stimulating the triceps, and the biceps tendon reflex here. The one thing I'll point out is you notice in this picture that the practitioner is using their finger to kind of hit the reflex hammer. And that's because it would be pretty painful if you were just hitting the tendon with the reflex hammer directly. So always make sure that we're not hurting our patients while we're performing their neurologic exam. All right, so weakness and ataxia is one of our super common clinical signs as well, and it can be seen with lesions in any part of that cervical spine, so either C1 to C5 or C6 to T2. So tetraparesis or tetraplegia would be how we describe this, meaning either weakness of all 4 legs or total paralysis of all 4 legs. So the front limbs or the hind limbs may be more severely affected, and that's going to be dependent on the location of the lesion, as well as the severity of the lesion. You can also have a proprioceptive ataxia. So again, that's trouble knowing where the legs are in space. So either knuckling on the front legs or buckling over, a lot of owners will describe it to me as scuffing of the toes of the front legs, or even crossing over the front legs. And I often describe these guys as looking like a drunken sailor. So they're wobbly and they don't know where their legs are. They're either really wide stepping or really narrow stepping. And that ataxia is because of the interruption of the signals that kind of help to coordinate that movement. They can also have a bit of a floating gait, so almost an overreaching gait. It's a little bit different than a hypermetric gait as you would see with a cerebellar or a brain lesion. But the floating gait is where they kind of pause for a moment during gait and during the stride before putting their leg down. And we can see that with lesions higher up in the cervical spine. I didn't have a great video of that, unfortunately, because that would have been a fun one to show. And lastly, a two-engine gait. So in a two-engine gait, it's more common with our caudal cervical lesions. We can have a short, choppy thoracic limb gait, and then a long, loping stride in the pelvic limbs. And we'll see that here. So this is Candy. Candy was an 11-year-old female spayed pit bull mix. She actually presented to us for a back problem. And that just speaks to, the thought that the back legs can look so much worse. However, when we saw her gait, we were most concerned about a neck problem. She also only had proprioceptive deficits in the back leg. She had normal reflexes, and she wasn't super painful anywhere on her exam. So I want you to watch her gait here, and I'm going to play this a few times for you. All right, so this is Candy's dad. She didn't want to walk with me. But you can see here she's having a little bit of difficulty. She's a bit ataxic, and she's kind of scuffing those back legs a little bit. And you'll notice, especially towards this part of the video, that those front legs are super short and choppy. I refer to them as tap dancers when I talk to my pet parents, or twinkle toes. So they really just kind of tap, tap, tap their way along in the front legs. And I'll play this one more time after this. I want you to focus on the front legs here, all that short choppiness. And then we'll rewind once more. And again, focus on the back legs here. So the back legs are long and loping. She scuffs them. She has a really long stride in those back legs, especially compared to the front legs. But you can tell that that's not quite normal for any dog, even if the front legs weren't the way they were. So that's what we call a two-engine gait. We did do an MRI, and Candy had a slip disc at C7, T1. She recovered fully after surgery and did great for us. All right, and then this is Rowdy. Rowdy was, I believe, an 8-year-old male neutered Rottweiler who came to us. He had a 2-week history of acting a little bit off, and then a 48-hour progressive history of inability to walk. So you'll see Dr. Wang and Giovanni here trying to walk the big man. I let the heavy lifting, I leave the heavy lifting to the guys. So you can see Rowdy here. Can't really move his legs at all, even with support. And we'll play this 1 or 2 more times for you. You maybe see a little bit of shuffling, but it's super subtle. So we classified him as a tetraplegic dog, meaning can't move any of the 4 legs. And he obviously had proprioceptive deficits in all of the legs. He's unable to replace any of those paws, even with support. So we did do an MRI. Rowdy had a slip disc at C5, C6. He stayed with us for some physical therapy for, I think, 2 weeks after surgery, but was nearly walking by the time of his going home. He needed a little bit of help to stand up, but could walk on his own after that. He just looked a little bit wobbly. So he certainly did quite well. Our big guys can take a little bit longer to get up after surgery. So that 2-week kind of mark where we sent him home and he's still wobbly is not uncommon for the bigger dogs. All right. Okay. The last clinical sign that we'll talk about is difficulty breathing. Oh, I think we skipped one actually. There we go. So The next clinical sign that we'll talk about is Horner syndrome. So Horner syndrome is a kind of collection of abnormalities actually within the eye. So meiosis, and again for our pet parents, meiosis is a small pupil. It'll be on the affected side, so on the side of the spinal cord that is most affected. Ptosis, or drooping of the eyelid, protrusion of the third eyelid, and then enophthalmos, or sinking in of the eye, and again all on the same side. And this is more common or common with a caudal cervical lesion. And the reason for that is because there is a sympathetic nerve that helps to control all of these functions of the eye up here. That nerve starts in the brain, but then travels down the spinal cord, and it ends in the spinal cord kind of at T1 to T3, so in that caudal cervical or cranial thoracic area. And we can see a Horner syndrome when we have a disc slip or a disc protrusion in that area. So again, that's one of the more subtle things that we look for on our examination to clue us into, hey, this must be a neck problem, as opposed to a back problem or a brain problem, for example. We have to put all of those clinical signs together. This pathway then travels cranially back to the eye, but it exits the spinal cord at that T1 to T3 level. And this is a picture of Horner syndrome. So you can see here, you can't really see that the pupil is smaller, but if you imagined this circle, you would see that it's a little bit smaller than this one over here. You can see the third eyelid being elevated on the left side of the screen or the right side of the dog's face. You can also imagine that the eye's a bit sunken in if you compare the two. And then if you follow the angle of the eyelids, you can see that this angle is much smaller than this angle, which indicates that these eyelids aren't open as much and are droopy. So this is obviously the more normal eye on the left of the screen, and on the right, on the right of the screen, and on the left of the screen is the eye affected with Horner syndrome. And lastly, the last clinical sign is going to be difficulty breathing. Now this is pretty rare, but it is an emergency situation. So dogs with slip discs in the neck can lose respiratory function. That's because the phrenic nerve exits the spinal cord in the caudal cervical spine. It's formed by the spinal nerves of C5 to C7. The phrenic nerve supplies the diaphragm, which is the muscle most responsible for breathing. And so this situation absolutely requires emergency intervention. It does unfortunately make us a bit more worried about the postoperative recovery period. Some of these dogs do require a ventilator even with surgery. So that's one of the situations that we have a really serious talk with our owners. Surgery is absolutely the right thing to do for dogs that are affected with difficulty breathing because of a slip disc. However, there can be postoperative complications, there can be postoperative challenges, and we like to be upfront about those things, but we definitely worry quite a bit when we see dogs that present with trouble breathing. The one that I'm going to show you here is Max. Max presented to us Friday evening on an emergency, and he came into us just for not walking in all four legs, and he had a really acute history, so over a few hours. Dad left him home. He was normal when Dad left, went to do some errands and came back, and Max wasn't able to walk. So he went to an ER who referred Max over to us. And I'll show you the video and then I'll point out some things. So this was Max just kind of while we were waiting to get him under anesthesia. And so again, you'll focus here on the lips, and you can see he's pulling his lips back. That's what I call a fish mouth or a fish gulping breath. So trying to suck in as much air as he can. And he's not as affected as some dogs that we see, which is why I felt comfortable taking video of him. The second thing that we'll look at is his belly. And you can see that when he breathes, his abdomen is moving in and out as opposed to his chest, which tells us that he's not able to use the muscles of his chest to ventilate like he normally should. So when that diaphragm can't work, they can't breathe through their chest as they normally would. So this, of course, is an emergency. We did do an MRI for Max, and he did have a slip disc at C4-5. We did emergency surgery for him. I actually think his MRI is a little bit later in the presentation, and he did really well for us. So Some differential diagnosis for cervical IVDD. Unfortunately, lots of things can look like a slip disc. So right age, right breed, things like that. I usually tell people a slip disc is most likely, but we have to consider the other possibilities. So inflammatory disease is one of my top differentials. A lot of the breeds that are predisposed to slip discs are also predisposed to inflammatory disease or autoimmune meningitis, myelitis. So we have to talk to owners about that being a possibility because obviously treatment prognosis are quite different. Neoplasia is certainly possible, so whether it's a bony neoplasia or a soft tissue neoplasia. Discospondylitis, which for our pet owners is an infection of the disc space and the bones. Wobbler syndrome is more common in our giant breed dogs. Certainly something I was worried about for Rowdy, that Rottweiler that we saw. Ischemic myelopathy, so that's a vascular event. Can certainly occur in the neck. I think of it more commonly in the thoracolumbar spine for dogs, but can occur in the neck in cats. And cats we're not mentioning too much because they're pretty rare for slip discs, but can certainly happen. Congenital malformations are possible, including things like atlantoaxial subluxations. So those are common in our small breed young dogs, as well as Chiari-like malformation with formation of syringomyelia secondary to the Chiari. And that's again more common in our small breed dogs. So a lot of the breed predispositions and the signalment that we'd be looking for would be really similar to the dogs we expect to have cervical IVDD. And lastly, trauma. So we can definitely see traumatic fractures and subluxations, as well as spinal cord contusion after a trauma that can mimic IVDD. The tough part about all of this is that all of those can look the same from the outside, which is why we've got to do testing to determine exactly what's going on. So diagnostic testing. First, complete neurologic exam is most important. So obviously not for our pet parents, but for our referring veterinary community, being able to determine A, that this is a neurologic problem, B, where the dog localizes, and C, is it an emergency? Do they have to see a neurologist today or can it wait 2 days until the next available appointment? It's super important and really helps us out. I always recommend a minimum database, so just some blood work, just to make sure our pets are overall systemically healthy, especially if we're thinking about doing testing. We'll want to make sure before we put a dog under anesthesia that they have no other health concerns. Radiographs are a good screening tool. CT can be useful, and MRI scan is our gold standard. So radiographs are a great screening tool, like I said. They can suggest a disc herniation, but can't definitively diagnose a disc herniation. For referring veterinarians, you can always include the chest. Often before anesthesia, we're taking chest x-rays. So we will certainly, if you've already got the dog on the x-ray table, we will certainly take a look at your x-rays instead of repeating them. It can be difficult to position a dog for a cervical spine radiograph. They twist really easily, and especially when they're uncomfortable, it can be difficult to get a good picture. So radiographs for our pet owners are best at looking at bones. So we can see a radiograph of the cervical spine here, remembering that funny shaped C1 and then C2 and through 7. So the bones here, the spinal canal, I really hope y'all can see my pointer. The spinal canal would be in the center here, and then the discs would lie underneath, in between the bones of the spine. One of the things that I tell people to look for are the width of the disc spaces. So you can see this disc space here at 3.4 is much narrower than the ones next door. So that can indicate to us that there's less disc material in there, potentially where did it go, slipping into the spinal canal. However, that can't definitively diagnose that that's the current problem. We also see this as a top-down view as opposed to our profile or side view. So again, we see here that narrow disc space, and we're just kind of corroborating our findings by taking 2 different views. This here is another profile or side view. And again, the arrow here is pointing to one of the discs, which obviously looks different than the rest. You can't see the soft tissue well on the x-ray, which is why these all look dark. But again, as we mentioned earlier in the presentation, this is a mineralized disc, so it's one of those degenerated discs that has filled in with that gritty calcium-like material, which again can suggest that this is a weak disc, potentially could herniate in the future, or maybe is the one that has herniated a little bit, but can indicate to us this dog has some level of IVDD or disc degeneration. So we always recommend advanced imaging with an MRI being recommended over CT scan. The MRI can see bone, but CT is far superior for imaging bone. However, when we have a dog with a nervous system problem, a spinal cord problem, we want to see the spinal nerves, we want to see the spinal cord, we want to see the discs themselves, so we often prefer an MRI scan. Pros to MRI are that it is the gold standard. We get a great picture of the spinal cord and the nerves and the disc. It can also diagnose most of the other possible causes for signs of a neck problem. So can diagnose things like tumors and discus spondylitis. It can suggest inflammatory disease. So a CT will miss a lot of those things. The cons are that there's a cost associated with MRI because it requires anesthesia, which is the next kind of con. That's a really minor con. However, if a dog is systemically healthy, I don't worry too much about anesthesia, and that's why we do that pre-anesthetic testing. And it can see bone, but again, the CT is better for looking at bone. That's unlikely to be problematic, except in really rare cases, like that case of Johnny that we showed you earlier with that really lateralized disc herniation. That was tough to see on MRI because it's just a busy area to look at. So this is an MRI scan. Again, this is a profile view or a sagittal view. You can see in the middle, the spinal cord is that gray column or gray 2. And then the herniated disc at C23 here is this black to little bit of gray mass here. It's pressing on the spinal cord from the bottom. And you can see it lies right over where that disc space would be if the arrow weren't there. So treatment options for a disc herniation after we've diagnosed them properly with an MRI. We have two options, either surgery or conservative management. And the question is, how do we decide which option is best for each patient? So I decide based on the patient's history. Is this a first-time offender? How severe are their clinical signs? So if a dog only has neck pain and it's their first time having a neck problem, I'm fine to manage them medically. However, if a dog has had neck pain for, waxing and weaning for 6 months and we find a slipped disc, I'd rather tackle that problem head on and go to surgery if the owner's able and willing to do so. So when I have a neurologic problem in the neck, I split them up into 5 grades, with a grade 1 being a dog that's only painful. A grade 2 is a dog that can walk but is weak and wobbly in all 4 legs. A grade 3 is a dog that can move the legs but can't coordinate walking. So they can't walk without support. A grade 4 is a dog that can't move any of the legs but can feel the toes. And a grade 5 is a dog that can't move the legs or feel the toes, which is super rare but is an emergency. And often those are the ones that we do see problems with breathing and things like that. So surgery, we have 2 surgical approaches. A ventral slot's our most common surgical approach. So we actually go in from the neck because there's much less muscle there and a much direct route to the spinal canal. You can see there's muscles in the way. Also the trachea peeking in this illustration here. We'll have the esophagus and some pretty important vascular and nervous structures, around this area. So certainly surgery comes with its own set of risks. It's one of the reasons that we always recommend that a board-certified neurologist who has been trained in neurosurgery is the one to do the surgery, because there are lots of things that unfortunately can go wrong if we're not super careful. This is another kind of bottom view. So this is looking from underneath the neck. This would be if we dissected all of this muscle off here. And this is what we call the ventral slot. So we make a little coin slot in the bone that exposes the spinal canal to us, and the herniated disc material would be sitting there. We'd scoop it out and decompress the spinal cord. And this is just another illustration of what that looks like from a profile or side view, which I think is helpful in imagining what happens. So these are the bones here. The disc would be here. We drill a little bit through the disc, leaving a little on the outsides, which helps to stabilize the bones. That's where our surgery differs a little bit from human surgery, that we don't do a full discectomy and we don't do a fusion. And then that allows us access to the spinal canal to scoop out that herniated disc material. Okay, all right, and then the second type of surgery, which we don't do commonly but have to do in some scenarios, is a cervical hemilaminectomy. So that's where we actually take a top approach, and that's if the disc has herniated around the spinal cord and we can't reach it from that bottom or ventral approach. So these are, again, all of the muscles. You can see there's a lot more musculature, and if you feel your dog, you can feel the musculature on top there. We've got a really important ligament here, the nuchal ligament, that's got to be separated and kind of pushed to the side. And then we get a top view of the bones when we get through all of the muscle dissection. And then we do a hemilaminectomy, just like we do in the thoracolumbar spine. And that allows us to kind of access more of the dorsolateral portion of the spinal canal. This next picture here is an MRI scan of a dog who required a cervical hemilaminectomy. This was, if we go back, this was Max, that dog that was having difficulty breathing. So the arrows are pointing to the disc here. Obviously, this is the ventral portion there, and typically we'd go in from underneath, but this disc herniated and kind of scooted around the spinal cord and up over it. So we never would have reached that from going in underneath. And so we had to do a cervical approach. So those arrows there pointing to the disc that's herniated, mixed with a little bit of hemorrhage, and then the spinal cord getting pushed over to that side there. Max's disc herniation was at C5-6, and again, he did great after surgery. So the last part of the treatment, or the last treatment option, excuse me, is crate rest. So this is the most important part of the conservative approach if we're going to take a more conservative approach and not do surgery. The rest lets that disc heal, lets that annulus heal to prevent more of the nucleus from slipping out. It also helps any inflammation to subside. So no running, no jumping, no playing, no stairs. These dogs are essentially on doggy bed rest for a period of 4 weeks. They do a similar rest period following surgery, but it's so important in the conservative approach for it to be successful, for them to have that strict rest, even if they start to feel better. They go outside for potty breaks only on a leash and chest harness. And you can see here this dachshund. I picked him not only because he's a dachshund, but he's in a crate that is perfect for this confinement period. You can see he's got nice soft bedding. He's got a really plush, thick bed. It's nicer than mine. He doesn't have too much room to move around, so even though that seems cruel, the more they move, the more likely that they are to kind of torque something in their, in their spine and cause recurrence of their signs. So he can kind of stand up, turn around, and lay back down, and that's all I want them to be able to do during their rest period. So prognosis for disc herniations, this is one of the most important parts of our conversation with our owners. With surgery, we've got a really great chance of making them better. So in our grades 1 to 4, about a 90 or 95% chance of making them feel better and be pain-free. Takes a little bit of time sometimes, of course, but we have really good chances of fixing them. With a grade 5, which again is super uncommon, they've got about a 50% chance of walking again if surgery is performed within a 24-hour period of losing the ability to walk or to feel the toes. So postoperative rest is imperative again for a good outcome, and some pets may benefit from rehab following surgery. Not all pets need rehab, but we usually talk about that at their postoperative recheck examination to determine if it's necessary or not for a full recovery. With the conservative approach, there aren't many studies that look at, with cervical disc disease specifically, what are the outcomes with the more conservative route. However, just in my experience, about 50 or 70% of these guys that are in the grade 1 and grade 2 categories do recover with a conservative approach. And I typically reserve this approach for first-time offenders. So maybe I'm biasing my numbers a little bit there. There's, in my opinion, a less than 50% recovery rate for dogs that are in that grade 3 category, so they can move the legs but can't walk. And then for a grade 4 or 5 with a cervical disc herniation, the prognosis is quite guarded without surgery. So I always encourage those pet parents to move forward with surgery if they're able to give their pet the best chance of walking again. Owner compliance is key in the conservative approach, and I know I said it, they absolutely have to rest. That's the most important thing of their recovery, and I know it's tough. I know you've got to be kind of the, quote, bad cop to keep them in their crate most of the time, but it's so important for making them feel better. We can't explain to them why they have to be in there, so you've got to give them a little bit of tough love sometimes. And they do, unfortunately, with the conservative approach, have a 50% chance of recurrence because they have a weak disc. The discs next door will also be weak in turn. So I also warn my owners about that potential, quote, complication. And then lastly, some lifestyle modifications for dogs with IVDD. So avoiding high impact activities like jumping on and off the furniture, using ramps to the furniture. This is called the DOC ramp, D-I-C-H ramp. And it's all over my Facebook and Amazon ads right now. We also want to use a chest harness instead of a neck collar just to avoid excess stress or strain on the neck. They've already got some weak discs there. No tug of war. We can find other things that our dogs like to play, but tug of war again will put more stress and strain on the neck. And then lastly, I always recommend crating these guys when they're not supervised so that they don't do anything silly when we're not home and can't monitor them. The most important thing, in my opinion, is that they maintain a good body condition. So lots of my patients need weight loss after surgery as well, not only for their spinal health, but for their overall health. And then we have one case. I'll run through it relatively quickly because we're running out of time. So Max is a 10-year-old male neutered terrier mix. He came to us on an emergent baseless. He was restless and pacing the night before presentation. Then he bumped into the bed and all of a sudden could not walk. So initially he started after bumping into the bed with knuckling in his front legs. He went to his primary vet and he was really wobbly on his feet, but he could still walk. By the time he arrived at 7 and he was immediately referred that day, he was non-ambulatory. He had no motor function in his front legs, but mild motor function in the back legs. He was really painful in his neck, and he had absent proprioception in all 4 legs. So we localized him to C1 to C5, and this is his MRI scan. This is a slipped disc. It looks different than the last one that we saw. This is actually hydrated nucleus, so it's not degenerate. It's that healthy jelly-like nucleus that herniated out and is pressing on the spinal cord. That's why it looks so bright, because water looks bright on this particular MRI, and this kind of disc has a high water content. So a little bit different. This is called a hydrated nucleus pulposus extrusion, or HNPE. This was at C4-5. We did surgery on Max and he was actually walking the next day, which was quite remarkable. So I'll take some questions here. I realize we're running out of time, but we can stay a little bit longer. And so here, Dr. Weiner, does the treatment typically change for different Hansen type disc diseases? It really depends on the severity of the dog's clinical signs, as well as the motivation of the owners. So we do typically treat, if we're going to do surgery, we do similar surgery. I can't say honestly that I've ever seen a surgery for a Hansen type 2 in the neck, but I guess it's possible. But most of the time I do try to manage those dogs conservatively because they're typically our larger breed dogs with Hansen type 2 disc herniations. They typically get weaker after surgery, and it can be really tough for an owner to care for, you know, a 70 or 80 pound lab that is having trouble walking at home. So I always exhaust the conservative option in that case. Oh my gosh, there are lots of questions here. All right, so Wendy Hall, are signs typically progressive, or do dogs who have proprioceptive ataxia tend to stay there? So great question. Sometimes the signs can be progressive. For example, I saw a dog today that started with a little bit of discomfort and progressed to having an ataxia. So the reason for that can be variable, but in a disc herniation, the theory is that a little bit of disc slips out. We still have that rupture in the annulus, and if we don't treat them, or we allow them to jump on and off the furniture, especially things like that, a little bit more disc can herniate out and put more pressure on the spinal cord, which then affects different parts of the nervous system. So if at first we were just uncomfortable, if we allow some more disc to slip out, then we can have other clinical signs like ataxia and weakness or inability to walk even. To answer the second part of the question, do dogs who have proprioceptive ataxia tend to stay there? It's possible, but it's also possible that they do have progression. And I don't think this was really part of your question, but after surgery, our goal is always 100% recovery. However, some dogs can have residual deficits. So that's where it'll be really important to check in with your neurologist after surgery, not only to see, does this dog need physical therapy, but to get a baseline after surgery, because gosh forbid your dog was in one of the percentages of dogs who comes back with a second slip disc. We don't want to overinterpret those signs. So if a dog had a proprioceptive deficit after surgery that they retained and came back a year later, we don't want to think that that proprioceptive deficit is a new finding. We'll answer Emily Hardy. So I've heard that time is of the essence, and when you see clear signs to go into surgery before it gets worse, is this accurate? We think that here at Southeast Veterinary Neurology, time is certainly of the essence. There are some dogs that can get better with conservative management, and there are some cases, like we said, who I'm very comfortable managing conservatively. So always time is of the essence. If a dog is even just a little bit painful, we don't want them to be in that situation. So any signs of abnormality, I always recommend visiting with your veterinarian or your local neurologist. For dogs that are in that grade 3, 4, and 5, absolutely, we go to surgery the same day for those guys, and probably 99% of the cases. And even for the grades 1 and 2, we go to surgery the same day often. But you do have options in the 1 and 2 scenario, the grade 1 and 2, for them to try and get better with conservative management. All right, Dr. Weiner, again, do you use steroids for IVDD? You hopefully maybe know the answer to this question already. We always like steroids better than non-steroidals. I think actually we probably skipped a slide somewhere in there with the conservative approach for medications. So I use pain medications, gabapentin and tramadol, even amantadine in my super painful cases. I often add Valium. I like it a little bit better than methocarbamol for a muscle relaxer. And in the event that either my patient is not improving, or in the event that my owner says I absolutely can't do an MRI and my dog is not better or my dog is worse, then I will add steroids as an anti-inflammatory for a short course, always making sure my patient can handle steroids from a systemic standpoint. I think they work better than non-steroidals for the spinal cord, just in my experience. There are lots of studies that say that, and there are lots of studies that say the opposite, but I'm a believer in steroids for a neurologic problem. So I think Luis Bolanos had that same question. And then pain management, again, we kind of skipped that slide inadvertently, but again, using multimodal pain management, and adjusting medications if we need to. I typically do a 7 to 10 day course of pain medications after I've seen a patient for the first time. And if that doesn't control their pain, we make adjustments along the way. But even in a grade 1 that's just painful, if those pain medications are not controlling the clinical signs, that's when we know we have to take a more kind of aggressive approach. And then last one, I'll pick one more. Let's see. All right. Hi, so do you recommend fenestration in near discs during ventral slot surgery? Absolutely. So for those of you who don't know, fenestration is a prophylactic procedure that we can do during surgery to reduce the likelihood of disc herniation in the future. It's not 100% successful, but it does reduce that risk down to about 10 to 15%. It adds maybe 5 minutes onto surgery, so nothing significant in terms of the anesthetic time, and not a significant risk to performing fenestration. So it will absolutely be performed in almost every surgery that we do, and really decreases the risk of having a problem in the future, because as I always say to my owners, I never like to see my patients back for a bad reason, only for happy visits. So I will stop there. For whoever we have not answered, I will get back to you by email. I want to thank everyone again for coming tonight. I certainly appreciate it. Thank you to the Broward County Veterinary Medical Association for having me. And again, you'll get your CE certificates in about an hour by email. Please contact us if you have any issues with that. And have a great evening. Thank you.